Hello everyone. So I welcome you all to this discussion on the CNS5, that is the WHO 2021 classification of the CNS tumors. So this is from a neurosurgical perspective. So see, first, this is the fifth edition of the WHO CNS classification of the brain of the tumors, and fifth edition, and this is actually the sixth version of the international standard of classification of brain and spinal cord tumors. The prior publications were in 1979. The first one was in 1979, then 1993, then 2000, then 2007, and then later in 2016. That was the fourth edition, and now we have the fifth edition, and this is actually the sixth version. So these are different. So edition is the publication of the books and the materials. So this is the sixth version of the original classification. So why CNS5? This is a very big question. Why CNS5? See, there are many recent developments in the field of molecular diagnosis and histopathology, which was already followed in the 2016 classification, but the updates have been so much that the recommendations by the consortium to inform molecular and practical approaches to the CNS tumor taxonomy, that is the C-impact now. And these recommendations were taken, and the main aim is to advance the role of molecular diagnostics in CNS tumor classification, in addition to the traditionally used histology and, of course, the immunohistochemistry. So we are incorporating molecular diagnostics with histology and IHC. So that is why the CNS5 is very important. So the CNS tumor taxonomy, that is how a biohistopathology report is given these days. So it incorporates the molecular changes with the clinicopathologic utility that are important for the most accurate classification of CNS neoplasms. Grouped tumors. The CNS5 has grouped tumors according to the genetic change that enables a complete diagnosis. That is the IDH status, the histone 3 status, all these are incorporated in the tumor taxonomy. Names have been much simplified when compared to earlier. Only location, that is where exactly the tumor is located, the age, that is the pediatric or the adult type, and genetic modifiers like the BRAF mutation. In that way, the genetic modifiers with the clinical utility have been used. For example, now we have this extraventricular neurocytoma when compared to the earlier central neurocytoma. And tumors with highly characteristic features, that is, for example, the choroid gliomas that occur in the third ventricle. These are included in tumor definitions and descriptions, even if it is not a part of the tumor name. So if you find a mutation like this, BRAF C.1799 TAP VAL 600 GLU. What is this C and what is this P? So BRAF, BRAF is a mutation which just commonly happens in this scenario of gliomas. A sequence alteration relative to the transcript reference sequence is reported using a C prefix. So C prefix, that is a C1799TA. So that is actually the transcript reference sequence for the coding DNA sequence, followed by the nucleotide number and the nucleotide change. So here the nucleotide number is 1799 and the nucleotide change is T over A. Okay, so that is what is C.1799 T over A. Okay, so that is basically the coding DNA sequence followed by the nucleotide number and the nucleotide change. And then we have the P prefix. The P prefix will be there for the predicted protein sequence with reference to the amino acid number, and the variant amino acid resulting from the mutation. So it's basically here we have PVAL 600 GLU. So this indicates the amino acid number and the variant of amino acid resulting from the mutation. So this is what is the BRAF mutation. So earlier we used to call it as BRAF V600E. That was how it was called. Now we are expanded it. Okay. So use of Arabic numerals. Earlier we used to use Roman numerals in place of Arabic numerals. So now when like all other tumor gradings, now Arabic numerals are used instead of the Roman numerals. That is also a change which has been incorporated into the CNS5. So now a layered structure report will look like this. It will have the integrated diagnosis, that is the histopathological diagnosis along with the molecular diagnosis. Then it'll have the CNS WHO grade, that is in the Arabic numeral, and then the molecular information. So all these are included into the diagnosis. For example, it will be a supratentorial ependymoma not otherwise specified. NOS is not otherwise specified. So histopathological grading classification would be ependymoma. The WHO grade based on the histology that they see, it is going to be 3. And the molecular information here, NOS, why NOS? Because the tissue was not sufficient. So whatever tissue that they had derivatives extracted from the tissue were insufficient quality for sequencing and insufficient tissue for fish studies. So all this will be specified. So that it is easier to place additional therapy if needed for the patients. For example, radiotherapy or chemotherapy. So this will be the decider for most of the diagnosis. So we'll now go into the specific changes. This topic is very important. What are all the specific changes the CNS5 has included? So first we'll talk about gliomas, glioneuronal tumors and neuronal tumors. So these are divided into 6 different families based on the CNS5. So first we have the adult type diffuse glioma. The majority of the primary brain tumors in the neuro-oncology practice of adults, like the glioblastoma, IDH wild type. So this is the adult type diffuse glioma. Then we have pediatric type diffuse low-grade glioma. They are low-grade, hence they have a good prognosis. Then we have pediatric type diffuse high-grade glioma. So they are expected to behave very aggressively. And then we have circumscribed astrocytoma. Circumscribed means they are more solid growth pattern. So in that way, you can excise it completely, as opposed to the diffuse tumor types. Okay, so circumscribed is well defined. And then we have glioneuronal and neuronal tumors. That is these glial tumors which have some neuronal differentiation. And then we have ependymomas. Now ependymomas are classified based on the site as well as the histological and molecular factors. Okay, so earlier the gliomas classification was quite different. Now we have 14 newly recognized types have been added in this, and the existing nomenclature also been changed. For example, earlier we used to have the diffuse midline glioma H3K27 mutant. Now it is called as H3K27 altered. So because it is to recognize the alternative mechanisms by which the pathogenic pathway can be altered in these tumors. So in that way, some names have been changed. So what all the important things alone I'm going to discuss here. So the classification is now simple. Earlier in the 2016 classification, we used to have 15 types of gliomas. Now the CNS5, there are only 3 types: astrocytoma, IDH mutant, oligodendroglioma, IDH mutant, and 1p19q co-deleted, and glioblastoma, IDH wild type. So largely now we have only 3 types: astrocytoma, IDH mutant, oligodendroglioma, IDH mutant, and 1p19q co-deleted, and glioblastoma, IDH wild type. Okay, and the nomenclature 2016 classification, based on the histopathological parameters, the IDH mutant diffuse astrocytomas were graded into diffuse astrocytoma, anaplastic astrocytoma, and glioblastoma. In CNS5, all IDH, this is the older variant. In the older days, we used to classify it as diffuse astrocytoma, anaplastic astrocytoma, and glioblastoma, grade 2, grade 3, and grade 4. Now, what we are doing is all IDH mutant diffuse astrocytomas are considered as a single type. That is astrocytoma IDH mutant. That is it. And along with that, we are grading it as WHO grade 2 or grade 3 or grade 4. So there is no longer a diffuse astrocytoma, no longer an anaplastic astrocytoma, no, and of course glioblastoma we do have one. Okay, so grading is no longer entirely histological. This is also important because the presence of this specific mutation, that is the CDKN2AB homozygous deletion, this results in CNS WHO grade 4. So the presence of this mutation, that is a CDKN2AB homozygous deletion. So even in the absence of microvascular proliferation or necrosis, The presence of this mutation alone will take the tumor to WHO grade 4. So this is very important. Okay. So CDKN 2A/B homozygous deletion. The presence of this mutation itself is enough to take it to grade 4. And then we have the IDH wild type. So far we discussed about IDH mutant. So for the IDH wild type diffuse astrocytomas, the presence of one or more of the following genetic parameters is sufficient to grade it as the highest grade. So what are all the things? First, third promoter mutation. Then we have EGFR gene amplification. Then we have combined gain of entire chromosome 7 and loss of entire chromosome 10. So this mutation, or if there is one or more of any of these three mutations, then it is going to be glioblastoma IDH wild type. Okay, so glioblastoma IDH wild type means it should have any one of the three mutations, that is third promoter mutation, EGFR gene amplification, and of course the combined gain of entire chromosome 7 and loss of entire chromosome 10. So this will take it to IDH wild type glioblastoma. Then we talked about two pediatric type tumors. One is the pediatric low grade and the high grade. So first about the low grade diffuse gliomas. In the low grade diffuse gliomas, there are four types. One is the diffuse astrocytoma, MYB or MYB-L1 altered angiocentric glioma. Plenty, that is the polymorphous low-grade neuroepithelial tumor of the young, and diffuse low-grade glioma, MAPK pathway altered. So all these four types are low-grade pediatric type diffuse gliomas. Then when you take the pediatric type diffuse high-grade gliomas, then you have the diffuse midline glioma, that is the H3K27 altered, diffuse hemispheric glioma, that is the H3G34 mutant, diffuse pediatric type high-grade glioma, H3 wild type, and IDH wild type. And of course, the last one is the infant type hemispheric glioma. The term glioblastoma is no longer used in the setting of pediatric type neoplasm. This is very important. So diffuse high-grade gliomas, pediatric type, there is no more use of the term called as glioblastoma. So regarding the neuronal and the glioneuronal tumors, all tumors with a neuronal component have been grouped together. So what are these? You have DGONC, you have myxoid glioneuronal tumor, and then you have multinodular and vacuolating neuronal tumor. So the DGONC, that is provisional. See, what is this DGONC? It is nothing but diffuse glioneuronal tumor with oligodendroma-like features and nuclear clusters. NC is nuclear clusters, ON is oligodendroma-like, and the diffuse glioneuronal. So diffuse glioneuronal, oligodendroma-like features and nuclear clusters. This is provisionally added, and likely it is likely to be added in future in the future classification. And then you have the myxoid glioneuronal tumor, and then you have multinodular vacuolating neuronal tumor. So all these three are the neuronal and glioneuronal tumors. And then you have ependymomas. Ependymomas, based on the combination of histopathological and molecular features as well as the anatomic site, we are dividing them into three groups. One, supratentorial, that is in the cerebrum. Then the infratentorial, that is the posterior fossa, and then those tumors arising from the spinal compartments. So recent addition, molecularly defined types of supratentorial ependymoma, two have been added. One with the ZFTA, the new designation for C11ORF95. So ependymoma C11ORF95. So ZFTA, that is what is the new addition. And then you have one with the YAP1 fusion mutation. So one more with the YAP1 fusion mutation. So these are the two new additions for ependymomas. So two types of posterior fossa ependymoma group, posterior fossa ependymoma A and B. And of course, the spinal tumor are defined by the presence of the myxopapillary ependymoma and subependymoma. These are the two spinal tumor types that we commonly encounter. So now, earlier, myxopapillary ependymoma and subependymoma were considered as grade 1. But now myxopapillary ependymoma is considered as grade 2. Why? Because of its likelihood of recurrence, it is now understood to be very similar to the conventional ependymoma. You know, the conventional ependymoma is of grade 2 type. So similarly, myxopapillary ependymoma, because of its tendency to recur, it is now called as the grade 2. And similarly, we have the papillary clear cell, we have the papillary clear cell, tanicytic, and morphologic variants. So these are no longer listed as subtypes of ependymoma, being included instead as patterns in histopathological description. So earlier we had the papillary type, we had the clear cell type, and then we had the tanicytic type. So these are the subtypes that we used to have. Now they are considered as just morphological variants and not as separate subtypes. Okay. And WHO CNS5 allows only a histological defined diagnosis of ependymoma to be made at any of the 3 anatomic sites. The term anaplastic ependymoma is no longer listed. We no longer use the term anaplastic ependymoma. No longer the term anaplastic ependymoma is used. As for other tumors in the CNS5, a pathologist can still choose to assign either CNS WHO grade 2 or grade 3 according to the histopathological features. So based on the histopathological features, they can grade it. That's entirely up to them. But we do not use the term anaplastic ependymoma. Now, if you take now we'll come to medulloblastomas. Medulloblastomas, the 2016 classification, we group them into WNT activated, sonic hedgehog activated, group 3 and group 4. So sonic hedgehog, that is the SHH, was subsequently divided in based on the P53 mutational status, whether it is a TP53 mutant or TP53 wild type. Okay, so these are the this is how the SSH tumors are divided based on the P53 mutation status. New subgroups have emerged at a more granular level below the 4 molecular subgroups. So earlier we had the WNT pathway, SHH, and the group 3 and group 4. Now we have 4 subgroups for the SHH and 8 subgroups of the non-WNT and non-SHH medulloblastoma. That is the group 3 and group 4. There are 8 subgroups. For 4 subgroups for SHH and 8 subgroups for non-WNT and non-SHH medulloblastomas. So like the 4 principal molecular subgroups are associated with the clinical pathological findings. They have a certain diagnostic, prognostic, and predictive value. So that is why it is important. For example, the delineation out of the 4 SSH subgroups, SHH1 and 2, they are dominated by medulloblastomas from young children. So this, and another importance is they have a significantly different outcome, and they have a better response. Some will have a better response to chemotherapy when compared to the other subgroups. And basically, we used to have 4 morphological subtypes. Like we had the classical variant, we had the desmoplastic or nodular variant, we had the medulloblastoma, extensive nodularity, which is supposed to have a very good prognosis, and then we have the large cell or anaplastic. Now, they have been combined into one section that describes them as morphological patterns of an inclusive tumor type. That is medulloblastoma, histologically defined. And of course, the large cell and anaplastic do have a bad prognosis, but now we have a more integrated classification. And the morphologic differences, for example, all true desmoplastic and nodular medulloblastomas, and the medulloblastomas with N-nodularity. So most of them are SHH1 and 2 subgroups. They have a very good, they have a better prognosis. All WNT tumors will have a classic morphology. Again, they have a good prognosis. And then we have the large cell anaplastic tumors, which belong to either the SSH3 subgroup or the group 3 or group 4 subgroup 2. So they have a quite poor prognosis. So even then, again, the morphological features, along with the histological subgroups, even they have some alignment based on the morphological patterns also. So other embryonal tumors, we have the ATRT, that is the atypical rhabdoid teratoid tumor. Then we have the embryonal tumor with the multi-layered rosettes, that is the ETMR. Then we have the CNS neuroblastoma, FOXR2 activated. And then we have the CNS tumor with a BCOR internal tandem duplication. And here you have to know that the CNS neuroblastoma FOXR2 activated and the CNS tumor BCOR internal tandem duplication, that is the last two, they are new to the CNS5. And similarly, it recognizes three molecular subtypes for the ATRT and ETMR with a dicer1 alteration. Regarding pineal tumors, they are neoplasms arising from the pineal gland. You have pineocytoma, you have pineal parenchymal tumor of intermediate differentiation, then you have pineoblastoma, then you have papillary tumor of pineal origin. So, in addition, this is what we have traditionally. In addition to that, there is a desmoplastic myxoid tumor of the pineal region with the SMARCB1 mutation. This is a rare mutation which lacks histopathological signs of malignancy. So this is one thing that you have to remember. Okay. So, and similarly, the pineal parenchymal tumor of intermediate differentiation, they have this mutation, that is a KBTBD4 in-frame insertions. So at least the highlighted things that you have to remember, that is the newer additions. That is, for example, here we have the desmoplastic myxoid tumor of the pineal region, SMARCB1 mutation. This is a new addition to the already included pineal tumors. Regarding meningiomas, what is important is, regardless of the underlying subtype, that is, it could be rhabdoid or papillary, that itself is not enough to grade it as grade 3. The more recent studies have showed that the histology, that is the architecture of the rhabdoid or the papillary architecture, is alone not enough to take it as grade 3. Several molecular biomarkers are also associated with classification and grading of meningiomas. Like we have the SMARC SMARCE1, that is the clear cell subtype seen in the clear cell subtype. Then we have the BAP1, which is seen in the rhabdoid and the papillary subtype. Then we have the KLF4/TRAF7 secretory subtype mutations. Then we have the third promoter mutations, which is CNS grade 3. Then we have the H3K27ME3 loss, which has a very bad prognosis. And similarly, we also do the methylome profiling for the prognostic subtyping. And new subtypes that have been added, this is for regarding the mesenchymal and non-meningothelial tumors. See, earlier we used to call them as hemangiopericytoma. Nowadays, the term hemangiopericytoma has been removed from it, and we only use the term solitary fibrous tumors. So some new subtypes have been added. This is the intracranial mesenchymal tumor. Then we have the FET CREB fusion positive. Then we have the CIC rearranged sarcoma. Then we have the primary intracranial sarcoma, dicer1 mutant. So all these are new subtypes. But what is the MCQ point for you? What you have to remember for the exam is, there is no longer a term hemangiopericytoma, and now we only use the term solitary fibrous tumor instead of that. So regarding the nerve tumors, paragangliomas are now added here in the nerve tumors. Why? Because they have specialized neuroendocrine cells of the sympathetic and the parasympathetic nervous system. And also both IHC and DNA methylation differences and the lack of familial associations, the paraganglioma of cauda-equina phylum terminal region, that region alone is considered as a distinctive tumor type these days. Okay, so that is the newer thing. So first thing, paragangliomas are included in nerve tumors. And second thing, paraganglioma of the cauda-equina or the phylum terminal, they are grouped together as a single. They are grouped together as a distinct entity. And then there is previously there is one melanotic schwannoma. There is one term called as melanotic schwannoma. Previously, this was used. It is highly distinctive and a very aggressive tumor with unique genetic changes that distinguish it from all the other nerve sheath tumors. So, in accordance with this soft tissue classification, the term melanotic schwannoma has been changed to malignant melanotic nerve sheath tumor. So the term melanotic schwannoma is no longer used. Rather, malignant melanotic nerve sheath tumor is what is used. Then we have one ANNUBP. So what is this ANNUBP? It is nothing but atypical neurofibromatous neoplasm of unknown biological potential. Atypical neurofibromatous neoplasm of unknown biological potential. So it is associated with the NF1. And the only thing is, it has a malignant transformation. that is not sufficient enough to be termed as malignant peripheral nerve sheath tumor. So ANNUBP, it is a new subtype of neurofibroma. It has a malignant transformation, but not as malignant as a malignant peripheral nerve sheath tumor. So now coming to the tumors of the cellular region. Earlier we had adamantinomatous craniopharyngioma and papillary craniopharyngioma. They are considered as distinctive types, but now they are classified as separate. They are now classified as separate tumor types itself. Earlier they considered it to be subtypes, that is variants of craniopharyngioma. Now they are distinctive tumor types itself because of the different clinical demographic features, radiological features, distinctive histopathological features, genetic alterations, and methylation profile. So because of this, now adamantinomatous and papillary are no longer considered as subtypes, but rather they are considered as distinctive types of the area itself. And there is a new term called as pituitary neuroendocrine tumor, PITNET. So it has been proposed by the WHO endocrine group, which will further elaborate it in their endocrine classification. So there is, you remember for now that there is one term called as pituitary neuroendocrine tumor. And then you have pituitary blastoma. This was a question which was asked earlier. Pituitary blastoma is a very rare embryonal neoplasm of infancy. It is composed of primitive blastomal cells, neuroendocrine cells, and Rathke's epithelium. And this is added in the CNS5, recently concluded CNS5 type. Okay. Okay. So that is the this will conclude our discussion on the CNS5. So I hope this session was useful to you. So now I'm coming out of the screen share. All right. So I believe this session was useful to you. And now you can text me on WhatsApp if you have any doubts regarding this. All right. Okay. So on that note, I'm ending the session. I believe the session was useful for you. So basically, at least the highlighted parts, that is the new additions, you have to remember. That is what is very important for you. Okay. So all the best for the upcoming INISS exams. And this session is mainly for orienting you to the newer additions. And don't go depth into the CNS5 classification, because there is too much for a neurosurgical perspective. All that is important is for you to learn the newer terms that have been added and what all have been removed from the existing classification. All right. So on that note, I am ending the session. Thank you very much.